Episode 21, a hand cyclist with forearm pain. Welcome to Sports Medicine Case Studies, where I review published case studies in sports medicine. Our patient today is a 35-year-old right-hand dominant male with a complete T7 spinal cord injury from a snowboarding accident 4 years prior. He presented to the clinic with severe pain, erythema, and swelling over the lateral aspect of his left forearm, about 2.5 inches proximal to the anatomical snuff box. He had just completed an epic 7-hour mountain hand cycle climb, 3,000 feet of elevation gain to 11,000 feet. His training previously had only involved 90 to 120 minute sessions once weekly. This was his first ride exceeding 2 hours, and the pain began abruptly after about 5 hours of pedaling. He described it as a sharp stabbing sensation with each pedal rotation. So severe, he thought he had a stress fracture. By the time he returned home, he could not transfer to his wheelchair or propel it effectively. On physical exam, there was localized erythema, tenderness, and edema over the dorsal aspect of the distal forearm. The pain was worse with wrist extension, and finger flexion and extension also triggered discomfort. Importantly, there was no crepitation with motion, and Finkelstein's test was negative. Sensation was intact, but the examiner noted mild weakness in the wrist and fingers, which was attributed to pain. His radial pulse was strong. Differential diagnosis that I came up with: de Quervain's tenosynovitis of the second or third dorsal compartment, intersection syndrome, or possibly Wartenberg syndrome, which is entrapment of the superficial radial nerve from where it emerges beneath the brachioradialis. I want to recognize the author. It's Dr. Yonette. He published this in Topics in Spinal Cord Injury Rehabilitation in 2013. I'm Scott Hull, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in 2026, and I hope you'll join me on the journey. This podcast is for educational purposes only. Okay, our patient underwent ultrasonography of the forearm, which demonstrated a fluid collection around the tendon sheaths of the extensor palpus brevis and abductor palpus longus at their intersection with the extensor carpi radialis brevis and extensor carpi radialis longus. Our patient was diagnosed with intersection syndrome. He was prescribed a wrist splint and naproxen 500 milligrams twice daily. At 1 week follow-up, he had developed significant crepitus and associated squeaking with thumb abduction. But his pain had improved. By 2 weeks, crepitation pain had resolved, and repeat ultrasound demonstrated complete resolution of the fluid collection. Our patient had an excellent recovery. He maintained his cardiorespiratory fitness using a stationary hand cycle, but changed to vertical handers, which don't require wrist flexion and extension during pedal rotation. He completed a marathon 5 months after the injury and 10 marathons within a year. He resumed off-road hand cycling with horizontal handles at 8 months, but limited his sessions to under 2 hours. Okay, so key takeaways. Intersection syndrome is an overuse injury characterized by inflammation at the crossing point where the abductor palpus longus and the extensor palpus brevis, the first dorsal compartment, intersect with the extensor carpi radialis longus and brevis tendons, which are the second dorsal compartment. This crossover or intersection occurs in the distal forearm, and it's approximately 4 to 6 centimeters proximal to Lister's tubercle on the distal radius. This condition results from repetitive wrist extension and is most commonly seen in weightlifters, competitive rowers, and individuals with significant increases in wrist extensor use. Patients present with pain on the dorsal aspect of the distal forearm, and late presentations may include redness, warmth, crepitation, or a characteristic squeaking sound during wrist extension. The dorsal location of the pain helps distinguish intersection syndrome from de Quervain's tenosynovitis, which generally presents more radially and more distally. The underlying pathology of intersection syndrome is stenosing tenosynovitis of the sheath of the common radial wrist extensors. On imaging, as in our case, the most characteristic finding is peritendinous edema around the first and second extensor compartment tendons extending proximally from the crossover point. This condition typically responds favorably to conservative treatment, including activity modification, anti-inflammatory medications, and relative rest. Okay, question 1. A 28-year-old competitive rower presents with pain and swelling on the dorsal aspect of his left forearm, approximately 4 to 6 centimeters proximal to the wrist. He reports a squeaking sensation with wrist movement. On examination, there is tenderness and crepitation at the affected site. Finkelstein's test is negative. Which anatomical structures are involved in this condition? A. Extensor pollicis longus and extensor indices, which are the third and fourth dorsal wrist compartments. B. The extensor digitorum and extensor digiti minimi, representing the fourth and fifth dorsal wrist compartments. C. Abductor pollicis longus, extensor pollicis brevis, and the extensor carpi radialis longus and brevis, which are the first and second compartments. D. Extensor carpi ulnaris and flexor carpi ulnaris. E. Flexor pollicis longus and flexor digitorum superficialis. Okay, correct answer, should get this one, is C. Intersection syndrome occurs at the crossing point where the tendons of the first dorsal compartment, the abductor pollicis longus and extensor pollicis brevis, cross over the tendons of the second dorsal compartment, the extensor carpi radialis longus and brevis, approximately 4 to 6 centimeters proximal to Lister's tubercle. Question 2. A 32-year-old weightlifter with intersection syndrome is treated with a cock-up wrist splint at 20 degrees of extension and anti-inflammatory medications. At 1 week follow-up, his pain has improved, but he has developed significant crepitus with thumb abduction. Which modification to his splint would most effectively immobilize all involved tendons? A. Increase wrist extension to 45 degrees. B. Add a thumb spica component to the splint. C. Switch to a volar wrist splint. D. Remove the splint and begin early mobilization. E. Add an ulnar gutter component. Correct answer is B. A cock-up wrist splint immobilizes the wrist and thus the ECRL and ECRB tendons of the second compartment, but does not adequately immobilize the thumb. The development of crepitation with thumb abduction indicates ongoing friction between the first compartment tendons, and a thumb spica splint would immobilize both the wrist and thumb, thereby resting all 4 tendons involved in intersection syndrome. Studies indicate that well-immobilized patients heal in approximately 12 days, while poorly immobilized patients may have persistent symptoms. Question 4. A 40-year-old recreational cyclist presents with dorsal wrist pain. On examination, there is tenderness at the radial styloid, and Finkelstein's test reproduces her pain. She has no crepitation, no tenderness proximal to the wrist. What is the most likely diagnosis, and which dorsal compartment is primarily involved? A. Intersection syndrome, representing the first and second compartments. B. De Quervain's tenosynovitis, the first compartment. C. The extensor pollicis longus tendinitis, which is the third dorsal compartment. D. Extensor carpi ulnaris tendinitis, the sixth compartment. E. Wartenberg syndrome, which involves the superficial radial nerve. Correct answer is B. The clinical presentation, including tenderness at the radial styloid with a positive Finkelstein's test and no proximal forearm tenderness, is classic for De Quervain's tenosynovitis, and this condition involves a stenosing tendinitis isolated to the first dorsal compartment, which includes the abductor pollicis longus and extensor pollicis brevis. Okay, thank you. See you next time.